Melody Mulaik is the president and co-founder of Coding Strategies Incorporated and Coding Metrics Incorporated, located in Atlanta, Georgia. She is a frequent speaker and author for CIS and other nationally recognized professional organizations and publications. Melody's area of expertise includes billing and collections, coding and compliance, revenue enhancement, front-end hospital operations, management engineering, medical school relations, and operations improvement. Melody frequently speaks for AHRA on topics ranging from the latest coding and reimbursement topics to operational challenges associated with charge capture. Melody writes the Coding Corner for AHRA's Radiology Management and serves as an AHRA liaison to the American College of Radiology Economics Commission. Prior to founding CSI, Melody held the position of Vice President of Billing and Compliance for the largest national billing company, where she was responsible for the implementation and maintenance of billing compliance programs. Ladies and gentlemen, please welcome Melody Mulaik.
Thank you. Thank you. I know I have the task of making sure that everybody stays awake after that wonderful lunch that we just had, but hopefully we've got enough new information to kind of keep you on your toes with that. I will tell you that the handout that you have, they were on the back for that. It is not going to exactly match the presentation, and the reason that it's not is we just got the new codes yesterday. So I updated with the presentation with as much as I could, and I've already talked with Jennifer, and I will send an updated handout that will include all the information that is in there, and you will get that after the conference. So you will notice when we reach that point where I say this isn't in the presentation, you will get that information later. So I'm not keeping it from you. It was just one of those, wanted to get the information into the presentation so that you have it. Anybody who doesn't believe there's a lot going on in healthcare, I could make that a statement, or I could say as a question mark. Right now, I hear people talking, saying, well, we're coming out of the recession. And I say, well, not in healthcare we're not, because there's a lot of uncertainty about everything. There's still a lot of uncertainty. We're not exactly sure what's going to happen in 2010. You're saying, well, that's what this presentation's about. I can only tell you what we know right now. As of today, September 30th, as we're looking at the information. We don't have the final rules yet. The final rules come out usually around Halloween, so we're actually expecting it on Friday, October 30th. We'll get the final rules for the hospital side and for the physician side, and that's what's going to tell us really what's going to happen in terms of reimbursement, other types of things. If we've got some new codes that Medicare is going to create, all that information will come out at the end of October. So what I'm going to give you is what we know based on the proposed rule. So what came out in June and what's the government been talking about. I'll also let you know about the new codes, give you an update on PET, and if we have time, we'll talk about just some overall standbys that we have problems with, such as orders and things like that. If we don't get to that in the presentation, that's fine, because I'd rather spend the time with what's new and what's going on in that particular area for it. So that's what we're going to talk about, what's going on with compliance, reimbursement, just give a quick update on the Medicare administrative contractors, CPT 2010, our PET, and then other areas as well. So first, let's talk about everybody's favorite, compliance. Okay, compliance is a really broad brush term that can refer to, are we billing things correctly, to the legal contracts between physicians and hospitals, or their ownership into imaging centers and those kind of things. I don't step into the legal arena. I'm not an attorney, so we'll leave that to the attorneys. I'll mention a couple of things that relate to the proposed rule. I know some of you that have heard my presentations before have seen this picture. I still love this picture. This is a real traffic light somewhere in Europe. And it just is really good to represent a lot of times what we're dealing with when we talk about coding and compliance, because the rules are always changing. And while that may be good job security for some of us, that creates a very challenging environment as we start to look at it. One of the things I wanted to mention that has come out over the course of this year is last year in the OIG work plan. OIG is the Office of Inspector General. They're the group that goes and does audits and looks for where Medicare could spend less money. And it doesn't just apply to healthcare. They do it for other areas too. And they say these are areas that you want to pay particular attention to. And last year they said we're going to go look at where there's a high utilization of ultrasound services. Well, they did that. And then they released a report over the summer. And a lot of people say, well, what does that really mean? What was this when they started focusing on ultrasound? So I want to give you a little bit of information of what was in that report and whether or not it should concern you for that. So what they found in doing the report was there was a lot of ultrasounds being billed in very specific locations across the country for that. So looking at this report they published in July, this overall data, Medicare covers about 17 million ultrasound services. That's a lot. Paying out more than $2 billion for ultrasound. Now that's less than MRs and CTs and things like that, but obviously $2 billion is being spent just by Medicare, not counting private payers, just on ultrasound services. So they found 20 counties in the United States that were in the top 1% for both billing average allowed ultrasounds per beneficiary and the percentage of beneficiaries who received ultrasound. This shows you how much they can dig into the data, doesn't it? They can run all sorts of reports to try to see, where do you fall in? Are you an outlier with certain things? So they really honed into these 20 counties. Here's the counties. There's Walker County in Alabama. In Florida, I know it's always a surprise to go after Florida, Broward, Charlotte, DeSoto, Indian River, Marion, Miami-Dade, Palm Beach, St. Lucie, and Sarasota. Some of you may even be from one of those counties. Michigan picked one county, New Jersey had 3, New York had 5, and Texas had 1. So those are specific counties that they focused on and said something doesn't look right in terms of ultrasound. So what they found is of that money we just talked about, 16% of all the money they spent on ultrasound was found in those counties, despite the fact that only 6% of the Medicare beneficiaries live there. So almost 20% of all the money spent for ultrasound by Medicare was in those 20 counties. Now some of those are obviously very big counties, like Broward County, and some of the other ones, maybe some of the other ones not so much so. And they found that also in those particular counties that they were using 3 times higher average spending per beneficiary than any place else too. So just some interesting data with that. So when they did their audit, they found 1 in 5 ultrasounds was actually, there was concerns raised whether or not it was appropriate. And they looked at things like the ordering a physician for it, were there weird combinations of services. There were even instances of more than 5 ultrasounds by the same provider on the same day. Now that sounds a little strange, doesn't it? I mean, we can see 2. Maybe in some odd situations, maybe 3, but even that would be really odd. But we could see a lot of situations with 2, but 5 in one day for some of the providers. So they looked at those and went through and talked about all the different pieces of it.